Dr. Helft will present the results of the OPTIDUAL trial, 12 versus 48 months of clopidogrel after drug-eluting stent placement.
Yes, thank you. Good morning. It's a pleasure being here. On behalf of the OPTIDUAL investigators, I will present to you the results of the OPTIDUAL randomized trial, 12 versus 48 months of dual antiplatelet therapy after the drug-eluting stent placement. As you know, the optimum duration of dual antiplatelet therapy, DAPT, after the drug-eluting stent placement remains very debated. The large DAPT trial has shown that compared with aspirin therapy, prolonging DAPT for 18 months, 12 months after DA's placement, reduced the risk of thrombosis, reduced the risk of MACE, but was associated with an increased risk of bleeding. And few studies have addressed the specific question of very long-term DAPT. Therefore, we are keen to demonstrate that on a background of aspirin, continuing clopidogrel for up to 48 months would be superior to stopping clopidogrel at 12 months following drug-eluting stent implantation in reducing net adverse clinical events, a composite of death, MI, stroke, and major ISTH bleeding. Therefore, we have conducted a randomized, multi-center, open-label study in 58 sites in France between January 2009 and January 2013. OPTIDUAL trial was funded primarily by the French Ministry of Health, and we received additional grants from Fédération Française de Cardiologie, Cordis Boston, Medtronic, Terumo, and Biotronic. This is the study design. 12 months after a DS implantation, patients who were still on aspirin and clopidogrel and who had remained free of MACE and bleeding were randomly assigned to receive clopidogrel for an additional 36 months or to discontinue clopidogrel. The primary outcome was a composite of death, MI, stroke, and major bleeding. And this is the main result of the OPTIDUAL trial. As you can see, extended DAPT could not demonstrate superiority in terms of reducing NACE compared to 12 months of DAPT. The primary outcome occurred in 5.8% of the patients with extended DAPT and in 7.5% of the patients with aspirin alone. These are the Kaplan-Meier curves of the components of the primary endpoint: death, stroke, MI, and major bleeding. The rate of death did not significantly differ between the two groups. There were numerically lower rates of death, stroke, and MI with extended DAPT, which did not achieve statistical superiority. And importantly, the rates of major bleeding were identical, 2% in each group. This is the post-hoc analysis of ischemic outcomes, death, stroke, and MI. And as you can see, there was a borderline, but not statistically significant reduction of ischemic outcomes with extended DAPT. Therefore, we conclude in the OPTIDUAL trial that extending DAPT duration for up to 48 months did not achieve statistical superiority compared with stopping clopidogrel at 12 months with regard to net adverse clinical events. However, there was a borderline, but not statistically significant reduction in post-hoc analysis of ischemic outcomes with extended DAPT, and importantly, no apparent increase in bleeding and all-cause mortality with extended DAPT was observed. Thank you.
Thank you very much. Now open for discussion. Yes, there's a question there, here, and then please introduce yourself.
Lynn Peterson with Trends in Medicine. Did you analyze this by the type of stent? Is there a difference whether this is Taxus or everolimus or whatever?
Exactly. It's an excellent point, of course. The effect of extended DAPT versus 12 months of DAPT was consistent among pre-specified subgroups, including indication of PCI and, importantly, the type of stents. In our study, there was only 1/3 of first generation of DES. The majority of the stents were second generation of DES. No.
Yes.
Hi, Peggy Peck, over here. Peggy Peck with MedPage Today. So, in your own practice, in your own opinion now, what will you be doing? There is no statistical difference with extended DAPT, and then there's this hint, which may or may not be real, that if you extend it, that you might get some benefit. So now, when it's your patient that you're treating, what are you doing?
Okay, the answer remains difficult. In fact, our findings are consistent with the findings from the DAPT trial, showing the value of prolonging DAPT on the reduction of MACE. It is difficult for one patient to have a decision. I think that if your patient is at low bleeding risk, you may consider to extend DAPT beyond 12 months. But once again, it's a case-by-case decision and a difficult decision.
I think we need, in a way, better risk stratification after revascularization. That's of our patients. That's the message we can get from these results.
Exactly.
Yes?
How do you explain the lack of increase in bleeding in the DAPT group, since it seems that whenever you get efficacy, you're going to have an increase in bleeding? Is this something that you think is
exactly
works in real life?
As you said, we did not observe an increase in bleeding in the extended DAPT group. The first thing, it is a population with a low bleeding risk, because the people have not a bleeding during the first 12 months after DAPT initiation. And also, the trial of the POWER cannot exclude that we will have a significant increase of the same magnitude as that observed in the DAPT trial. We have to be careful.
Okay. There is a question down on the bottom.
Tricia Ward, Medscape, theheart.org. Was everyone only taking clopidogrel, or were any of the other P2Y12 inhibitors used in the trial as well?
No, in fact, we compared aspirin versus clopidogrel plus aspirin.
Question over here, and then...
I have just a question regarding the power of the study. Do you, if I understand correctly, the patient were consent and randomized 1 year after the PCI. So do you believe that one of the reasons for, let's say, the lack of difference is because the physician would believe that the patient would benefit from the treatment, did not include the patient in the study? That basically, if the physician believed that the patient should stay on dual antiplatelet, then the patient was not randomized.
You are right. These patients were first at low bleeding risk and perhaps at higher thrombotic risk. But in the real life, often you have to take the decision at 1 year, and you have to take the good decision, and perhaps you're right.
We have the last question over there.
Peggy Peck again from MedPage Today. I meant to ask this earlier, and I don't know, did you show this? What about late stent thrombosis? Do you have any data on that?
Yes, of course. In fact, the rate of stent thrombosis was very low in both groups. They did not differ statistically. And as in the trials nowadays, the stent thrombosis rate is very low, below 0.5% in both groups. Sorry? Exactly. Exactly.
Thank you,
In
Dr.
fact, the MI we prevent are outside the stent. They are not related to the prevention of stent thrombosis.
Thank you very much, Dr. Helft.